Okay, hello everybody and welcome. Thank you all for participating in this webinar today, especially to our amazing panel. This is a very important and very relevant topic as the global community are sort of reflecting on the past year that we have had in this pandemic experience. It's the first pandemic I've ever experienced, and we've learned a lot of lessons along the way. And so today we have an amazing panel of very, very diverse, experienced practitioners here to share their perspectives about the lessons that we've learned, but most importantly, the responsibilities that we as the international community are going to have to these populations who might not have access to strong health services or even to a vaccine for a very, very, very long time. So my name is Maddie. I'm the executive director at Insight Collaborative. I am an RN and I currently volunteer here in Turkey and in Greece with refugee populations. And I'm gonna let our panelists go and introduce themselves. We're just gonna go in order of who is in my screen. So Myron, we're gonna start with you.
Hi there. Thank you very much for having me. My name is Maren Gillis, and I'm a Canadian living in the United States. I am a philosopher bioethicist who's also an administrator in medical education. My biggest concern is social justice education in the international ethics community. And I'm happy to be here. And I have very interesting conversations with Michael, and that's also why I think I'm on here as well.
Yeah.
We got to thank Mike for the referral on that. Okay, Farah, you're up next.
Hello, everyone. My name is Farah Mohammed. It's a pleasure to be with you here today. I am the founder and director of Bile Consulting, a consulting firm that does research, community outreach, and education. Originally, I was born in Somalia, raised in Kenya as a refugee. The Dadaab refugee camps where I lived for almost 18 years. Currently, I live in the US. By training, I have a master's in public health and social work. I do a lot of stuff, but my focus is addressing health disparities affecting refugees and immigrants within King County, the largest county within Washington State. Thank you.
Great. All right, Mike, you're up.
Okay, I always hate this. So I never know what to say about myself. So I'm Mike Drusano, family medicine trained physician, strong interest and experience in international humanitarian work, worked in a variety of different settings, including, believe it or not, Somalia, but Somaliland and Hargeisa, like in the northern part of the country. But also, I think in recent years, I've taken more of an interest in humanitarian assistance in terms of refugees. So in 2016, I worked with SAMS in Greece. And then I made 3 trips to the Rohingya refugee camps in Bangladesh to treat survivors of Rohingya genocide there. And in 2019, just a few months before all this pandemic business started, I was effectively an Ebola infection prevention and control officer in Uganda due to concerns about refugees situation, refugees from Democratic Republic of Congo coming across the border into Uganda. And when, not if, but when Ebola was going to be brought over the border into the country. So yeah, it's a pleasure to be here, and also always a pleasure to be talking to Maren, and also to meet new people like Farah.
Great, thank you. Well, we have a really important topic to talk about today, and to everyone who is watching, whether you're joining from Facebook Live or from our attendance list here, if at any point throughout this broadcast you have any questions, please don't hesitate to post them in the Q&A box here. And for everyone who's watching as well, know that this is being recorded and we're going to be uploading this to our YouTube channel. So if you want to subscribe to YouTube, you'll be able to see this once it's available. And you can also subscribe to our newsletter, and we send out all of our archived webinars for educational purposes following the upload of each one of those. So I want to briefly, real quick, provide a little bit of background about why I put this panel together to have this discussion and why this is so important. as a humanitarian practitioner, I'm involved in a lot, just conscientiously observing the discourse that's happening regarding migratory health and the international community. And a trend that I've been observing, and I initially brought this up with Mike sort of casually in a conversation, was like, wow, you know, as these vaccines are becoming available and as rollout plans are being released and as flights are continuing, there's been a growing number of people who are saying, okay, great, well, we can go back to life as we knew it before. And something that's a bit concerning about this is that, as I'm sure is no surprise to people, when you look at these vaccine rollout plans, there's not a super solid guarantee that the populations that would be coming into contact with these international volunteers are going to be included in the rollout. And I think for all of us who've had any experience in these contexts, and anyone who's sort of a conscientious observer, it's clear to see that these populations don't have the best access to care as it is. And especially in the pandemic, you know, speaking from someone I've worked in camps and in urban areas, we were already quite depleted of access to medical care before the pandemic. And now this whole COVID-19 has added a host of access issues for these underserved and marginalized populations that were already there before. They've exacerbated them and they've added some new ones. And so I want to sort of start though by setting a bit more context for anyone who is watching this webinar who's not familiar with how severely health inequities and social disparities impact people, especially those experiencing forced displacement. So the first question that I have for each and every one of you is, I'd like you to please outline your experience witnessing systemic injustice as it pertains to healthcare provision for these types of marginalized populations. And as someone who's involved in this, what can you say in general, both before the pandemic and during the pandemic? What have your observations been on how these injustices are impacting their access to care? So our speaker order will go same as introductions, Mara and Farah, and then Mike, if that's okay.
Okay, thank you. So I think that's a really important question because we've been hearing a lot of these words like, you know, inequity and social, like systemic inequity, institutional racism, things like that in the healthcare context. And that's kind of tough to understand somehow. And I know you asked to talk about it before and after COVID, but I think that one of the lessons that folks are starting to learn from COVID is just how to understand this. In the United States, in the American context, let's say, because that's where I've been hanging out, there's huge social inequity and health disparities in this country. And what you saw was how come it is that folks who are African American and Hispanic are so much sicker with COVID than the population, like, you know, by the numbers they are in the general population. So, you know, comparatively, they're getting sicker much more frequently than people who white people, you know, so how is that the case? And so you have to look at things like access to care. You have to look at things like, and in this country, that's a terrible, but basically that's what we're talking about when we're talking about systemic injustice. And just another easy one, like where I'm working right now, when you look at, for example, physicians and what the ethnic and racial background of physicians is that in medical schools, for example, you have fewer than 10% of medical students who are African-American males. And that just doesn't reflect what's going on in the community, right? You know, that there's a very big difference. So you have to start to say to yourself, why is this the case? And once you start asking those questions, you get into bigger systematic things like social things. And that's what we mean by the social determinants of health. And I could talk for an hour about this, but I'll just turn it over to my colleagues. So I'm sure that they'll flesh that out in their own context.
Thank you, Maureen. Yeah, even though it is, you know, an oath that healthcare providers have taken to treat people equally and fairly, however, the experiences of refugees, immigrants tend to be different. They tend to have, you know, negative experiences at the healthcare facilities. Based on barriers that are unique to them. You know, when these systemic issues have been going on even before COVID-19, but they have become very prominent, you know, during COVID-19. And some of the things that I, you know, in talking to people, in doing community assessment and research with different entities, the things that we have learned is lack of diversity, for instances, creates issues for people when patients or who don't speak um, English or as their first language go to these facilities, especially COVID-19 testing sites, and they don't see people who look like them, they are more likely to be turned off and convey the same message that healthcare workers are not representative of the community. The other thing that that came up, during COVID-19 is that even though, as Marine said, um, COVID-19 disproportionately impacted in the U.S., especially people of color, immigrants and refugees, based on the work that they do, whether it is working as a gig workers, Uber driver or essential worker in a grocery store. They have been disproportionately impacted by COVID-19. However, when it comes to resource allocation, in the county where I live, in the southern part of the county, you tend to be very diverse than the northern part of Seattle. And for some reason whatsoever, when COVID-19 testing began, resources were placed in where people who were less diverse, less impacted by COVID-19, and those are the questions that came up. Why do we have so many testing sites in northern Seattle? While COVID-19 has disproportionately impacted people who are in the southern part of King County. So those are the things that came up, lack of translation or interpretation of translation services. Oftentimes, when policymakers are talking about or healthcare workers, they do translation of material, even though translation of the material can be questioned sometimes in terms of quality. But there are people who don't speak, who don't write and read. And when you translate some information into the language of those community members, and they don't read and write, that is has become a barrier. And the other thing that also has become a barrier is medical insurance. Testing sites tend to everybody, whether you have insurance or not, have access to free testing. However, when you go to the testing site, the first question they will ask you, do you have an insurance? And when people hear, do you have insurance? If you don't have insurance, the thing that comes to your mind is that you will be receiving a huge bill. Here in the US, medical bills are huge unless you have an insurance. So those are the things that turn off the communities, accessing testing services within areas that I know of. However, while testing issues have existed, and then vaccination came in. Now, while these people have been facing barriers in COVID-19 testing, now there are more issues. Schedule an appointment when you don't speak English. That's an issue. When you cannot navigate through the internet to look for facilities that are providing COVID-19 vaccination. It's not easy to navigate, especially when you don't have means of transportation. I think what's going on right now, the policymakers, healthcare leaders within the area that I live in, especially in King County, they realize that those issues now, more resources are allocated to areas where refugees and immigrant population live, And as a result, I think the equity gap in terms of COVID-19 vaccine distribution has been reduced, and they are working towards addressing those issues. Thank you.
Okay, so I'm up, I guess.
You're up,
So I
Mike.
think two things. Like number one, like Farad, dig in the background. Number two, I think it's concerning to hear everything that you're saying, especially in the setting of like metropolitan Seattle having a reputation as being like one of the more progressive parts of the United States, and to still see all of this kind of systemic injustice in regards to COVID testing and vaccination in place. I think just from my own personal experience, I think I just have to say that like systemic injustice is universal. It doesn't matter what country you're in. It doesn't matter what setting you're in. You know, you hear very frequently in medical world, people with limited English proficiency, refugees, immigrants, not really getting the exact level of medical attention that they need. And I could somehow understand how this arises, even just from a practical standpoint. It pains me to say, you know, yesterday in clinic, I had a woman originally from Nepal. Luckily, she spoke Hindi, and one of the medical office assistants also spoke Hindi. And, you know, she was earlier in the morning, and, you know, I was taking the history, and of course, everything takes twice as long to go through because you're doing it through an interpreter, and sometimes there's clarifications, and there's also like cultural translations that also need to occur, not just linguistic translations. And, you know, in my head, as I'm like, you know, furiously typing down everything that's being translated to me, I'm thinking like, oh my God, I have all these other patients that are in the clinic right now, and I got to get ahead and I got to see them. But then, you know, I think then a switch turned on and I was like, I need to chill. I think the other patients that are here are just going to have to be a bit understanding. This woman is vulnerable. She has limited English proficiency. She had a recent stay in the hospital. And it is my duty to get down to what is wrong, how I can help her best, and then also just treat the secondary medical issues that are occurring. Because if I don't, her health and well-being are going to suffer if she feels as if her concerns have just been trivialized by a healthcare worker. Her healthcare seeking behavior is going to change. And so, yeah, I took a deep breath and I was like, let's just continue. I'm going to take care of things until all of this woman's needs are eventually met. And, you know, I could see this also, you know, the micro level. And then as we're kind of like increasing more towards the macro level, you know, I'm in public health school at the moment. And in one of my formative assignments, I had to discuss about, you know, obesogenic environments. And, you know, I'm from Baltimore in Maryland originally. I'm so proud to say that's where I'm from. That's where I always tell people. But yes, I mean, the city of Baltimore has effectively engineered an obesogenic environment that is targeted the poor and largely Black population in Baltimore and the communities that are the most marginalized. And, you know, in far away in the Rohingya refugee camps in Bangladesh, for a refugee to be able to exit the camp, even if it was for legitimate reasons, legitimate health concerns, the layers of bureaucracy that were in place that managed to prevent that from happening. I even had a grandmother there. She clearly had some sort of cancer process in the throat. I saw it with my own eyes, this cancer. She had like lymphadenopathy in the neck, like enlarged lymph nodes, which is a sign that like the cancer has spread to other parts of the body. She was the sole guardian for a young child. They were the only two members of their family that were able to escape the genocide in Myanmar. And she needed to be seen urgently by an ear, nose, throat physician in town in Cox's Bazar. And the efforts to try to get this woman out of the camp to get the care that she needed, it was beyond Sisyphean. It was structured so that she could not get out of the camp to get the care that she needed. And, you know, we also heard about on the news the very like well-structured, robust vaccination effort in Israel. But then, you know, the Israeli health minister recently was stating that they had absolutely zero intention on vaccinating Palestinians, you know, the exact people that they were occupying, that are under their domain. They made it very clear, we have no plans on vaccinating them. And, then we take a look at it even in the global sense, the systemic injustice. And Fatima Bhutto wrote in The Guardian this past week about how the world's countries, rich countries, are literally hoarding COVID-19 vaccines, and how Canada, for instance, has purchased enough vaccines to vaccinate everybody in the country 5 times over. Yet, meanwhile, South Africa, one of the countries in sub-Saharan Africa hardest hit by the pandemic, can't seem to get any. And even if they are able to purchase them, they're actually have to purchase them at a higher rate than countries within the European Union. So, my impressions of systemic injustice is just take a look around. It's not that hard to find. You will see it.
Can I respond to Michael?
Oh, that's up to Maddie.
Thank you, Michael. As I said, I grew up in Kenya, the Dadaab refugee camps. It is an area, I don't exactly remember, I think 30 or 40 miles square. There's the Dadaab, the headquarter, and then 3 refugee camps surrounding. And for the time I lived there, it's exactly the way you talked about the refugee camps in which country was it?
In Bangladesh.
In Bangladesh. So for the time that I have been there, we are not able to get out of the camp for any reason. We are just in a big prison, and there are still people who are in that situation when they have serious medical conditions. It takes months and years to get the proper documents to get out of the refugee camp. Leave alone having adequate resources, even if community members, you mobilize and collect resources to address those needs. There's so many barriers to overcome just to access services somewhere within Kenya. So while those issues exist, I think refugees are seriously impacted by COVID-19 and other systemic issues, and those are the things that I always think about. And when you have been there in a place for such a long time, and there's no access to resources to other communities, just like a prison, I think, in my opinion. Thank you.
Yeah, and that's I think that's a very important point to bring up, that something I was hearing between all of the speakers in your responses is that, I always, because I work on the migratory pathway, I see these issues. We encounter the displacement factors much closer than you might experience those and contextualize those if you're working, say, in refugee resettlement in a safe third country, or even in the camps that I was working in Greece, and that's where I was introduced in the same group as Mike. We're seeing people very far along that journey. And I think it's important for us to remember that there's these systems and bureaucracies all along that pathway that people are encountering, and that we have to sort of recognize where people are coming from. And so if they do get to the point where they're resettled in a metropolitan area like Seattle, they could have a very long history of negative experiences within healthcare. And so for me, I always try to think of like these push versus pull factors of like, what could be pushing someone away from care. So that's your barrier right there, is that they're not obligated, they're not motivated to seek care. They know that they need care, but they're not willing to go experience it within the system for any of the reasons, whether they go to urgent care and have a negative experience because there's no translator and they're not able to talk about, or they're mistreated culturally, or they're trying to seek care, but there's all these different, you guys all brought up good examples of that, all of these different barriers that keep them from getting to do that no matter how hard they try. There's bureaucracy, there's language barriers, the scheduling is a huge issue now that there's so much competition for certain types of care within our system, and it is very easy for people who don't have the full resources to access them to be ousted by other people. And so I do want to transition into, I think, as Mike said, you can look around and see the injustices. I do want to reiterate how important it is, though, for us to remember that populations of people who are not proficient in the language where they are, who are in a third country where they're not recognized and given full access to care. We have a large population of undocumented people here in Turkey that's being very problematic, and back in the States, it's the same thing, that there's a lot of debate about how we'll be vaccinating people who don't have documents and papers. But from a practical standpoint, that's a lot of systemic and theoretical barriers, and I definitely don't want to minimize those. But also from a practical standpoint, those of us who are in healthcare, who are vaccinated, and as I said in the beginning, maybe international volunteers who are standard humanitarian volunteers who do food distributions or education programs, we all get vaccinated because we're privileged and we have access. So now, hypothetically, a year down the road, when all of these wealthier, privileged countries are vaccinated, I foresee it being very easy for us to sort of forget that not everybody had the same opportunity that we did to access vaccines. What responsibilities would you say that those of us who do receive the vaccine and who sort of get to say, okay, life goes on as normal for us now, what responsibilities would you say that we have, or what things should we be keeping in mind so that we support people who don't have those same privileges? And we'll go in the same order again, if that's okay with you guys.
Well, that's a really interesting question. And as everybody's been talking, and we've been talking about things, but putting it into an ethical language, and this is what I'm most comfortable in, is that when we were speaking to your last question, what I think everybody heard when we're talking about systemic injustice is, and social justice generally, is that one of the things is that we have this view ethically that as human beings, we all have dignity and we're all, intrinsically valuable as human beings. And what we've been hearing is that because of some other factors, right? Like because of not having a state, or because of the color of one's skin, or because of the language that one speaks in a, doesn't speak the dominant language in a dominant country, that they are literally being valued and treated differently. And that is unjust. That is just, that goes against the idea that we're all equal as human beings. It's just not true, right? And so these people's experiences do not count in the same way. So then we have, as you bring up, a group of folks who actually do care, about those folks, right? And so they're vaccinated. And to your point, like say we're vaccinated and it's a year later, like what do I do now? Because I do care about those folks, right? Like unlike, these systems that we're talking about, that they made, that all of these folks falling through the cracks. So I do care, what do I do? And that's a huge question, because I think that what we were talking about earlier is that I don't think it's necessarily, and maybe my other speakers will, this is something we can discuss. It's like, I don't know if this is a different situation than any other kind of situation where you're talking about a privileged person who does care, and to say, what is the best thing I can do to help those folks if I care?
I think that's a very good question. We all work for entities, for systems, and systems are designed to work the way they are, and people tend to feel comfortable. Change is not easy, and people don't like change. I think what we need to do is to be good troublemakers. Speak against the system, say where things are wrong, advocate for communities who are marginalized to access services, and the whole idea of a country like Canada or the US accumulating more vaccine than they need, specifically Canada 5 times more than they need. That's ridiculous. COVID-19 doesn't know any boundary unless we are all protected. No one is, safe. I think that COVID-19 should be addressed as such. It's not, it shouldn't be a few countries with limited resources having most of the vaccine. That is, I think, morally and ethically wrong. And we have to speak against those injustices and say that it's not right unless we put that pressure and say, this is not right and this cannot continue. I think things will remain the same. There are many countries in, for sure, I know East African countries, Somalia, Kenya, where people are dying tremendously. When I go to my Facebook page, every other post that I see, people sending condolences to family members, young people dying, elderly people dying. I think those are the issues that should be addressed to wealthier countries. They should equally treat the challenge and the issues that other less resourced countries are facing uh, like their own countries. And we uh, the people who are in these countries who are within the system should speak against those systemic issues. Thank you.
Okay, so I assume it's my turn. So I think, when I thought about this question, I thought of it more in terms of international volunteers. And I think your responsibility as an international humanitarian volunteer is to be very mindful and to be very self-aware as to how you present yourself when on site. So, for the foreseeable future at this point, your mere presence abroad implies quite a bit. It implies that not only have you now been fully vaccinated, but it has an implication about your inherent privilege. And, we've been talking about this concept of privilege over the last few years in the United States. And just the fact that you have a job with vacation benefits, where you can afford to purchase an airline ticket and accommodations and go volunteer without pay, is a sign of immense privilege. I think, especially in a world that's been literally turned upside down by pandemics and refugee flows in recent years. And, people could counter, and justifiably so, they could, well, I could be just lounging on a beach somewhere else. And that is true. They are using their time, their effort, their resources in order to, I think, try to help others make the world a better place. But they do need to realize that, like, just their basic background truly is a sign of their immense privilege. And so it's a way in which you act if you do manage to find yourself overseas. And yeah, I think going back towards the Budo op-ed in The Guardian, you're also coming from a place, not only have you been vaccinated, but, she details in her op-ed about how, in rich countries, you have people openly scoffing, if not declining, some of the best vaccines out there, Moderna, Pfizer. But meanwhile, we have, like, refugees, other vulnerable populations who would do anything just even to get a hold of the lesser known ones, the ones that are viewed as less desirable. And by that, I mean like Sinovac and Sputnik 5. I think it just goes back to one particular story from the time that I was volunteering in Greece with SAMS. And there was one SAMS volunteer who noted that there were a lot of stray dogs around the camp, and just took to feeding the stray dogs. But meanwhile, the food that the refugees were receiving, they had to line up sometimes for 2.5 hours at a time. It was food that was offered that was oftentimes not culturally compatible or religiously compatible. If they got like a sandwich, it was just, like bread that was stale, if not about to go stale. Maybe just like a thin slice of meat, a thin slice of cheese. And one of the refugees remarked, stray dogs are being fed better than us. And so I think a lot of when you are volunteering overseas at a time like this, you need to be very mindful. And this is one thing that I learned from, I think, a Facebook group where kind of like racial issues are being discussed. And like, you know, there's intent and there is impact. And you cannot ignore your impact, even if there was no malintent. And so you also, in many senses, you have to consider the fact that your mere arrival and participation in some of these efforts, in a way, sad to say, is kind of like rubbing in the faces of the people that you are trying to serve, that you are privileged and you are fully vaccinated, and you are in a space and you're in a position that they would do anything to be in. I have like other examples, but I think just in the means of time, I could I'll keep those to myself. But I think when you are volunteering internationally, especially at a time like this, but this is even at a time without COVID, I think you're doing it knowing that nobody else locally is available to do what you do. And probably at the same time, there's local capacity has been overwhelmed. And so they really do need somebody. And I think also too, you should be doing it with the intent and actually training locals to do what you're doing. And so therefore locals, if not the refugee population, so that the people that you were trying to serve are actually now going to be involved in their own rescue. And again, I think this is the hallmark of humanitarian response. This is like with or without COVID.
All very interesting points. One that I would really like to touch upon that that Mike just brought up is sort of that the humanitarian mindset in general. I think a question that I get a lot, I'm privileged enough to be a career humanitarian. That is a privilege beyond anything that I can say, because we're very underpaid. You have to have a very strong passport. In many ways, you have to be very well networked and have gotten really lucky. And that's been the reality of my career. And I'm incredibly thankful for that. But there's so many layers to that. And the privilege piece, I think, is something that I want to touch on one more time, because it's something that's been brought up in the answers of all of these different questions. And we sort of answered this in the last question, but the last one that I had for the panel is, so what can the general public do to contribute to these continued protective efforts? But I want to put a little bit of a twist on that and sort of say, so something that I say a lot to the people that I'm working with, both in the affected population and in the sector and as donors, fiscal contributors, is I see privilege as a currency. So since all of you seem so well versed in sort of recognizing that and knowing what that statement could mean, do you have any recommendations in your own context and your own experiences that you can say, if privilege is your currency and if you have a lot of that currency, what are ways that you would recommend people can use that wisely in their own capacity? So if they're not a doctor and they can't go and volunteer their time lending care, or they're not policymakers, but just the average everyday person, how can we be using our privilege points in response to some of the issues that we've been talking about here on the panel so far?
Okay, so I guess I'm just jumping in because that's the order that we've been going into. One of the things, and this is just from that I've found out, and I comes from a background that is not my academic background or the job that I have right now. And I used to, as a young person, I was very active in politics. And I did work for a sitting member. I worked for a Minister of National Defense. And as a constituency person, and one of the things that I found that so many citizens in their own, like in countries like Canada and the US don't know, is how much voice they actually have through their elected members. And for example, I had to answer constituency letters, and they all have to be answered, and if there's questions in them, you have to find the information for the constituent. And so I've found over again with young people, or just even folks my own age, that when they talk about something, and everybody wants to complain about how the systems are. But in democracies, we can talk generally about the big picture on, oh, we really don't have a voice. We do have a lot more than I think we just don't know how to do it. And so starting at that local level with your municipal governments, with your state governments or provincial governments, and then going to the national level and finding out how these things work, it does make a difference. And then you do find like-minded individuals, and you can write things like op-eds, and people's personal stories resonate. You know, like the stories that we've heard today, you know, of actual on the ground refugee experiences resonate. You know, like looking at Facebook pages and like that your Facebook page is just full of condolences every day, that resonates. People can relate to that at a one-on-one level, as opposed to this big system that we can't do anything about. So you may say, oh, well, I might be able not to solve the biggest crisis, but maybe I'll be able to help some people. And as I said, doing it in your thing. And also with regard to COVID, as all of us have been speaking about in our own like privileged Western nations, there's disparities here too, you know, so, and you have probably a lot more power because you know the networks in your home country more than you know the networks in other countries where you don't live. And so you could actually bring about change there. And so those kinds of principles and policies that you're making at a local level, you know, then those could maybe have the currency or get people's mindset and to ramp it up, you know, to the global level.
Thank you, Maureen. I think that's a very good question, and people should understand that, you know, they can be that refugee, and you know, and it takes a lot of courage just to be a refugee, to go to other countries, and regardless, people should be treated, you know, in humane way. For you know how normal or ordinary people can support refugees and international humanitarian is already Maureen has touched on that. I think people have a lot of power if they can tap into that power individually and as a group. I think the first is to know there's a need for change and then organize. I think a number is a power. If certain number of people raise issues and there's so many ways to raise issues, and today we are very fortunate and sometimes not fortunate to have a social media. I think we can voice our concerns, people who are in power, the policymakers, and those should be, I think, the first strategy. And change is possible. For instance, in Washington State, where we live, there are so many immigrants and refugees, and the health outcome for your zip code where you live determines your health outcome. If you live in certain places, you are more likely to have negative health outcome, obesity, you know, diabetes, and so on and so forth. So, and the reason is the system is not designed to address those issues. So, Somali Health Board, a non-profit organization that I'm part of, realize that. And when you go to the doctor, you know, you need an interpreter. That interpreter may not be there. The doctor may not know your cultural needs and where you're coming from. And when somebody doesn't feel that they are welcome, that they're listened to, they're more likely to stay away from the doctor, not have preventative care. And the thing that we realized was, you know, there are many international trained medical doctors who are either driving Uber, who are maybe who are doing jobs that they shouldn't be doing. And we say, how can we, you know, utilize these medical doctors whose skills are wasted? So we came together, we reached out to policymakers and said, you know, this, you know, our communities disproportionately impacted by, you know, negative health outcome. They're more likely to be sick. So we, you know, working with the legislatures or policymakers, we passed a policy, you know, a policy where those medical doctors can be trained or get residency within our state, so that eventually they can give back to these communities who they understand more than any other person, because in terms of culture, in terms of language, in terms of skills, some of them have at least 10 years, 15 years of training, yet their services are not utilized.
Okay, so I guess I'm up. I guess what can the general public do to help with protection efforts? I mean, I guess no matter what the situation, it's probably donating funds to a local organization. Like cash is always welcome, but it's, of course, if you can support it at a time like this, a lot of people's finances have suffered as a direct result of the pandemic. I think also local advocacy helps. I think it's like Farah was mentioning. And also I think kind of going back to what Maren was mentioning, reaching out to your elected officials, ensuring that refugees, undocumented people are able to be vaccinated as well. Because I think if word gets out in this very interconnected world that, you know, parts of the USA, for example, are vaccinating refugees and undocumented people, other countries might take notice and follow the example. And I think maybe for people who are still very much interested in volunteering internationally, you know, I would say probably at a time like this, again, like if you are able to support it, just consider at this time donating any funds you would have otherwise spent on traveling to and from the site to an organization doing this sort of work. Just because there are a lot of organizations, even though they've had to scale back their efforts as a direct result of the pandemic, they are still operating in some capacity one way or another. There's at very minimum, I think, a local skeleton crew that's at least still trying to make things happen. And donating the funds that you otherwise would have spent on travel and accommodation would actually help out significantly.
And someone here has made a good comment in the chat here, important point on representation of underrepresented populations. I think that that's an important message for all of us to take away, you know, is who are we centering at a lot of the discourse surrounding this virus. And I think that the op-ed that Mike brought up is a good example of that, and some of the experiences that those of us who've worked directly with refugee populations, you know, we've experienced, we've witnessed, or even experienced ourselves the frustration of the spotlight sort of being shown in the wrong places. You know, there's a reason that these populations are marginalized, and it's because often there's no public pressure for them to be brought to the center and to have their specified needs focused on and addressed in an appropriate way, you know? And so, yeah, these are all really important points. And I also like that this comment mentioned social media, that, you know, some of us kind of hem and haw about Facebook and about Instagram or TikTok, whatever. But at the end of the day, people are spending a lot of time on these platforms. And it is really important to be sort of not just as far as what you're promoting and where you're sort of choosing to shine the spotlight, but also what you're consuming. I think that COVID has unfortunately brought to light the terrifying reality that a lot of people are susceptible to consuming and internalizing information that really, if you just gave it a second thought, you can be like, does that really make a lot of sense? Is that something that I should be along for? And so, yeah, that's an important point to bring up. So I don't want to eat into too much time here, but we do have a question in the box. I'm going to do my best. I can't quite understand what this is asking. Can you guys, panelists, see the chat box, by the way? Are you able to see the Q&A box? So there's a question that's been posted in here. And actually, as I was reading it, it gave way to a question that I think it would be important for us to touch upon briefly. You know, all of us having experience as providers and practitioners, whether that's clinical or in public health and systemic practitioners. This question, it says, do you think that the calls by some health promoters to release full primary data on vaccines, so it's a data protection concern? let's have a quick conversation about the ethics of that. And if whoever, it was anonymous, whoever posted this, if you want to clarify and ask the question again, that would be awesome. But I actually would be interested to hear, especially as it pertains to migrants and refugees. Now, keep in mind, this is a topic that could and should have a whole webinar of its own as far as protecting the data of people. But something that hasn't come up yet in the conversation is that in the experience that I've had working with undocumented populations all over the world, in the Middle East, in Europe, in the United States, a lot of the hesitation and the fear around seeking care is that their personal information and their personal safety might be compromised by entering the health system. And it was an issue before, it will continue to be an issue as we move through trying to get people to be vaccine compliant. What thoughts do we have on that? Have you guys seen any examples that would sort of reinforce why it's important for us to be advocating for better communication with these populations so that they will be incentivized to seek care? Does that freak you out if you hear that concept of like, well, we'll be collecting information from all these populations about their vaccine compliance and health status? Do we have any general thoughts on that? I know that's a can of worms, but if anyone wants to just jump on and share, that would be awesome.
Well, there's a number of things. So when we talk about any kind of health data, right, that people have, I mean, the biggest ethical concern about health data is confidentiality. And one of the things I like to teach the medical students when they come in and we're talking about oaths, and one of the things that we do in the classroom is that we look at historically, and geographically in different parts of the world, all different kinds of oaths that healers throughout the ages and in different countries take, and we compare and contrast them. And one of the things that is universal is confidentiality. That there's something about a provider and a patient in whatever context that's inviolable, and that's the confidentiality. So when we live in a world of big data, and you mentioned before, and I went for my vaccine, I do have health insurance, and so that's what I gave to them. So there is a documentation of my health insurance, but you didn't have to have health insurance. Like, that's the point that was brought up earlier, is that you actually don't have to have insurance to go get the vaccines in most of the public health places in the States. And so what do you do when you sign up? And I worked at the clinic, so I know what the information asks, and they don't ask that, right? And it doesn't go into the system, but I can completely appreciate why that wouldn't be trusted, and that's something that we have with all undocumented undocumented people, like people who don't have documentation properly to be in the country to receive whatever. And it's tough because at certain clinics, like we know, if you want to get care, like free care, if those clinics in the United States, they cannot, it's just difficult for people without documentation to get healthcare. It's just all across the board. And so when you're going to go to a place and they ask if you're documented or not, unless you have full confidence in the confidentiality, you don't know where that data is going, because there were computers everywhere where I signed up. It just wasn't me going and getting a shot. There was some documentation in somebody's database, about that. So even though that wasn't asked, I understand the hesitation. But I wanted to point out, though, that confidentiality is something that, with regard to any data and health data and ethics, we have to make sure is respected.
Well, and I want to touch on that real quick from a in the field standpoint, is that one of the issues that I've been noticing in the humanitarian sector since I started here, and I myself started as a quote unskilled humanitarian practitioner. I didn't go to school for humanitarian practice. I was not yet a registered nurse. I was one of those volunteers who showed up, fortunately with a lot of, I was scared into being humble. Like, I immediately was just like, I don't know what is what here. This is terrifying. This is out of my control. And so I'm just going to shut up and listen to what people tell me. But not everyone has that mentality. And so something that's been terrifying to me lately is seeing the number of people who come into the sector and have access to all of this information about a very vulnerable group of people, and who don't recognize the responsibility that comes with having that information. And so, I like that this question was asked, because not only is there the standard data protection concerns, who is this being shared with? Is this being shared with governments or drug manufacturing companies, who has access to this data, but then at the same time, it's who is handling this data. Do they recognize the responsibility that they have to be taking in this information? And I guess it's sort of in the same vein of what Mike was saying, is like, you need to recognize the responsibility that you have coming into the situation. Even if you're like, well, my intentions are good. We always say the road to hell is paved with good intentions. You've got to be really cognizant of that coming in, that you know how to handle that information appropriately. And I think all of us as practitioners sometimes take that for granted, that HIPAA compliance was like drilled into us from the beginning of time, and not everyone has that experience and background coming into these contexts. Does anyone else have anything to add about that?
Yeah, I mean, I think kind of following up on what everybody's been saying, yes, I think in any type of humanitarian response, it's humility and responsibility. Absolutely. If you're not going to come in humble, if you're not going to come in responsible, probably best that you just don't come at all. But, you know, it's a tough question to answer, the issue about data and times like this with vaccines, especially with marginalized communities, because the Paris riots back in 2005, what a lot of people pointed to as kind of what helped engender those riots was that for the longest time in France, it was illegal to take data based on people's like ethnicity or origins or racial background or whatnot, because they want in the whole spirit of like, oh, but we're all French, it doesn't matter like what our origins are, we're all French. But when you don't have even critical basic pieces of data like that, it doesn't really allow you to address these types of inequalities. If you take county X in the United States, and the official records say that the county is 70% white born in the United States, and the remaining 30% are people of color, immigrants, refugees. But if the people identified as having received a vaccine are now like 90% white and in the United States, it then allows you to ask why aren't we reaching these other communities that actually does need it? But understandably, I think coming from a place where there have been a lot of people who have suffered at the hands of authority one way or another, why then they would be reluctant to provide that information. And so it's just a very difficult situation all around, is really all that I can say.
Yeah, thank you, Mike and Michael and Marine. I think, keeping information of patients, secure or safe should be a priority for any healthcare provider. If your information is shared with other people, that can have a catastrophic impact. For the data, Michael has already touched on that. I think the data can influence policy, making. For instances, the disparities that he touched on in the US, that's a reality. Majority of the vaccines were going to white people, and that has raised issue, and people had to rush to address those issues. And now in King County, we are seeing, because of that data, we are seeing the gap of vaccine inequities being narrowing. So I think collecting adequate information from patients without compromising their confidentiality is very important for decision making. The other thing that that can address those issues are providing resources, allocating resources. We know these people have so many barriers, face so many barriers to access healthcare services within the community. Then if that, then address, hire people who look like them. People are more likely to trust if they can find somebody who speaks their language, take resources to within the community where people don't have to travel very long distances. You know, if you have in downtown Seattle, for instance, a facility that provides testing services or vaccination services, you know, even when you go there, you can have problem finding a parking space if you have a car. So take the resources, where the communities are, where the need is most. And the other question, is, are you providing culturally sensitive, culturally appropriate information, and taking that information to where the communities can find, whether if people have, if they don't write, provide them videos or that are translated into the language. If they can read, provide them translated information in their own language. And all those needs, I think, need a lot of coordination, a lot of resources, and that should be intentional. Unless you are intentional, we are intentional, whatever we're doing, we can assume that we are doing good job, but we may not be doing. For the humanitarian, the same case, I think, even though I don't work internationally, what I do see and realize, when talking to people, I think humanitarian workers and international organizations should also be intentional about, people that they work for. The workforce should be, representative of people who are being served. You will, at times you will see people who are highly trained, who speak multiple languages, not having opportunities even in humanitarian field. Why is that the case? So I think there are so many things to unpack. However, I think there are so many inequities and so many barriers for both, local and international work. Thank you.
Well, I think I'm just going to say something here. When we were asking before about what folks who have the impulse to do international humanitarian work who are vaccinated now could do, we've just got a list from Farah of all the different things that need to be, because that's a complex coordinated thing. And I could do that much more easily in my hometown than I could otherwise, or, my home state or my home country, and put together those kinds of things. And to one of the questions that we had in the chat box about social media, of the things that this pandemic is showing us, that in this webinar is a representation of this, is that for those of us who can have access to computers and Zoom and stuff like that, we can have a lot of different kinds of conversations that we couldn't have otherwise, and we're used to it. And it's very easy to do. Like, we're having a webinar right now. It's with people from different parts of the country in different countries, and in real time. And I think that folks could coordinate those efforts that are very complex. But to say, okay, we're going to help these folks in our community that come from this particular, these kinds of immigrants or refugees from this kind of country, to help those folks here now and find all the resources to do that. And it might seem small, but it's such a, you're talking about impact, you're talking about the consequences of a small thing. That would be huge.
Absolutely. Everyone, if you're good on time, can you give me a thumbs up? Because we have one more question in the box, but I have a feeling that it might lead us down a bit of a path here. But so someone's posted, and this may seem like an easy yes or no question at first, but this might be worth discussing. Should people, if they so wish, have the opportunity and choice to give and receive healthcare anonymously? What do we think about that? If it's okay for me to start with that, with just some thoughts from working again largely with undocumented or very vulnerable populations, in just for some context of how things are looking in the Middle East and Mediterranean area right now. A couple of days ago, there's an organization that's very well known for helping with new arrivals into Greece via land, mostly the sea crossing in the Aegean between Turkey and Greece, and they're called Aegean Boat Report. and how it used to work when we had a little bit more trust in the authorities and before a lot of these really bad human rights violations that they've been committing came to light. They would take a lot of this information that was given and they would publicize it and they would use that data, and they would be using, you know, the names of organizations who were referring them. But unfortunately, there was then a lot of backlash from the authorities because, again, from that systemic issues, it was perpetuating a systemic problem, which is these countries saying, we do not want these people coming. And then the burden of those consequences was coming down on international actors and on the affected population themselves. And so for me, that was the first time. Before, if I had read this question, I would have said, absolutely, yes, we should have this opportunity. But I've been walking on eggshells lately, you know, as a humanitarian actor and as someone living here among populations, and I understand the hesitancy now. I truly understand the hesitancy. So, you know, from a hypothetical ethical standpoint, maybe if you could answer this question in two parts. From a hypothetical ethical standpoint, what is your knee-jerk reaction to that based on what we learned in the books? But if you have any experiences in practice in any part of the world that would maybe influence that decision in reality for you, would you be willing to share any of that with us? Can you guys see that question if I put it up? Okay.
Well, I think we have to remember that, you know, when we talk about confidentiality of health information, there's exactly one reason why we say that that can be violated, and that's in a public health emergency, especially with infectious diseases, right? So I think that, so in the theoretical realm where all things are working the way they should, you know, there'd be confidentiality and you wouldn't have access to the data with your name on it. You can get it de-identified, right? You know, but when it has to do with a public health emergency, especially in the realm of infectious disease, like what we're talking about in COVID, then that you are justified in breaching that individual's confidentiality because of the greater good, because that has, you know, the implications of that person not being monitored, you know, and seeing what they're doing, what their contacts are, is worse house for everybody else, right? So I see that. Where I see it and where I've read about it in not doing it comes in the context, especially with women's reproductive health, you know, where you would not want, like, that's not something that has anything to do with a public health emergency, but, you know, when you have those kinds of issues, and that brings up really, really difficult concerns for the health practitioner and their patient, if, you know, in those kinds of situations. So again, it's important to, I think, you know, on the one hand, like to have the general feeling, like, you know, the general idea of what we mean by ethical and when it's okay to breach it. And then once we get into those on the ground cases, to describe what we're compelled by.
I would say, yeah, I wholeheartedly agree with Maren on this, in that, yeah, there's one particular procedure well known in women's healthcare where, yes, it's the new modern day scarlet letter. And if it did get out that they did have that particular procedure, that yes, you know, it could be life altering, it could be highly damaging. And so, yes, I think in certain circumstances, for instance, if it is like a one-off procedure or whatnot, I think provided that there is appropriate follow-up, it's understandable to see how one would just want to have things done anonymously. I also think too, you know, if there are anything that could be socially stigmatizing, for instance, if you're a sex worker, for instance, you're engaging in a line of work where, yes, like there's a huge social stigma against it. Understandable how you would probably want to keep that under wraps. You would want to be anonymous. However, you know, if it's a particular trait of yours that is a longitudinal risk to your health, I think that's when maybe the whole anonymity starts to become, the lines that start to blur a bit. You know, as Maren said, when it's a question of kind of like infection control, public health concerns, you know, the health of the greater population in general, we probably do need to be a bit more involved. And frankly speaking, I think it would behoove everybody involved, including the patient in question, if there maybe was a little bit of a lack of anonymity, if obviously with confidentiality in place. But, you know, for instance, if a particular clinic, you just happen to have a very good working healthcare worker patient relationship with a sex worker. If they notice that they had an occupation related infection, because you have a good relationship already, you don't have this coldness of anonymity, they're probably then more likely to actually come in and seek care.
I don't provide direct services to to patients. However, I think having, especially where where resources are allocated based on the the number of people within an area, it provided that I think confidentiality is in place where confidential information, personal identifiers are kept confidential, and they will not cause any impact. Sometimes, having that data will help proper allocation of resources where people, facilities can say, we serve this number of people, and these are, the target number. And the other thing can be, liability. If you provide services to someone and you have no any record whatsoever, if something goes wrong, that person has to come back to somewhere, and there has to be some kind of accountability at the end of the day. In this country, especially, I mean, when I'm saying in this country, in the US, where everything has to be, if something goes wrong, there's a legal process where somebody can be sued, or so if there's no record whatsoever, I think that would be a challenge, in my opinion. I'm not a direct service provider to patients, but that's how I see it.
Yeah, all very good points. And I think that too, when it is a public health issue, this is something that we're taught in nursing school now that I'm studying public health as well. It's like when it has the potential to massively impact other people, it's a bit different. But wouldn't it be nice if we lived in a world where when we didn't have to worry about having this information? I hadn't had that experience before where I felt burdened with information because I was like, oh man, something really bad could come of this. And so we're a bit over time, and I want to thank all of you so much for hanging around through the end of this. I want to thank you all for your contributions and for lending us your Saturday morning to speak about this issue. I would love to have you all on future webinars to keep discussing some of these things. I think the benefit of the diverse panel is that we got so much value with just a few people, but I think it would also be nice to get to dive into some of the unique parts of each of your respective sectors and careers. And thank you all so much. Thank you to all of our participants. And this will be available on our YouTube channel and on our social media. So if you missed anything, had to hop off early, or want to share this with your networks, please do so liberally. But thank you all so much. Have a great evening, and I hope we can do this again soon.
Thanks for having us on.
Thank you.
Yeah, thanks you guys.